But one of the things that we've seen in the state of California program is its success. 93% of the participants says this was a helpful program for me in order to support my recovery from stimulant use. I mean, that's a really remarkable outcome.
Welcome to Dopamine Dialogues, the show where we meet experts working with contingency management, translating the science into what actually succeeds in clinics, communities, and day-to-day operations with patients, clients, and beneficiaries. So whether you're a provider, payer, or policymaker, or just CM curious, you're in the right place. I'm Larry Klemchek, your host. It's with great pleasure that today I get to welcome our guest, Dr. Brian Hurley. Brian is the medical director of the Bureau of Substance Abuse Prevention and Control for LA County of Public Health. He's also the immediate past president of the American Society of Addiction Medicine, ASAM, and he's the current board member of ASAM. Welcome, Brian.
Thanks so much, Larry.
Hey, Brian, tell us a little bit more about yourself. And in particular, how did you come to have a passion about substance abuse and becoming really an industry expert?
Well, I grew up here in Los Angeles, California, where I was born and raised in the San Fernando Valley. And I had a chance to see, growing up, the different waves of substances as they've come through California, but really the United States. And I got really interested in how methamphetamine works. So I actually did a neuroscience degree at UCLA and was really interested in the science of how the brain responds to drugs. And one of the things I recognize is just how little evidence-based practices are delivered in the community, right? That we had a system for treating substance use that was largely punitive and punishment oriented. And I thought, gosh, we could do a lot better as a society. And the healthcare field can really help improve the health and wellness of the community in ways that are dramatically different. So it actually prompted me to go to medical school to practice addiction medicine. It really sort of came out of this idea of the science was interesting, but the idea of making an impact in the community was even more so.
Wow. Wow. Well, that's fantastic. And as you were just saying that, I could see it in your eyes.
Yeah.
You're just as passionate maybe today as when you decided
Yeah, I
to.
get up every day and I'm really excited to work for the health department and help advance the treatment of addictive disease. It's a really exciting opportunity.
Now, one of the things that you said there is maybe in the past it was punitive, it was punishing people for their behavior. And really, you're moving towards evidence-based treatment. Share with us how in your role today in LA County, how does that all come together for you?
Sure. Well, the most common interaction people who use drugs that have been classified as illegal have with any sort of system is the carceral system, right? So people get arrested for having the disease of addiction because there are criminal penalties associated with that. For the people that sort of happen to make it to treatment, which is actually not the majority of people, treatment also borrowed from the carceral system's framework, where you were supposed to go to treatment for a certain amount of time. So I would hear things about 28-day programs or 90-day programs or a one-year therapeutic community, all of which were very intentional and I think well-intentioned models to try to help people. But one of the problems with that model is that it assumes that people with addiction all kind of need the same thing. You need this type of box or that type of box. I'm not talking about jail boxes. I'm talking about treatment center boxes. But there's this idea that somebody has to go away to a treatment program for a fixed amount of time. As it turns out, people aren't boxed shaped. So you mentioned I'm on the board of ASAM, the American Society of Addiction Medicine. And there's a national standard for what care is appropriate to people at one time. So on one hand, addiction's a chronic illness. I want people to be in long-term, ongoing remission. But I also recognize that people might need different levels of care or different interventions at different points in their recovery. And that duration and that intensity of treatment needs to be based on them rather than we're in a 90-day program and treatment's going to last 90 days if you stick around. And so the state of California in 2015 adopted the ASAM criteria as the standards for publicly funded substance use treatment. In 2017, Lake County went live with using American Society of Addiction Medicine criteria standards for medical necessity for publicly funded treatment. So I have the privilege of being really this interface. How do we build treatment around people as opposed to expecting people to shape themselves the way treatment would want them to?
One of the things I was going to ask is evidence-based, and one of the evidence-based areas of treatment is contingency management, and that's kind of the main focal point of our podcast. But could you share with us how that fits into some of your roles and responsibilities, and if you'd like, what some of maybe ASAM's thoughts are on contingency management?
Sure. I'll actually start with ASAM's thoughts because I think it leads into what's happening in the state of California and then locally here in Los Angeles. So, the American Society of Addiction Medicine put together a national guideline on the treatment of stimulant use disorder that covered the medications and counseling and support strategies. And that's a wide range of prevention, harm reduction, treatment, recovery strategies that work to help people impacted by methamphetamine, cocaine, or other stimulant use. And the guidelines strongly emphasized the contingency management that is giving people an incentive when they stop using stimulants is like the recommended treatment and can be combined with everything else. You can do contingency management and counseling. You can do contingency management and medication management. You can combine it with anything else. Full disclosure, I and Dr. Moon at UCLA co-chaired the writing of that, right? So it is a project close to my heart. And in 2023, LA County began operationalizing the state's contingency management program using public funding to support contingency management at county contracted non-residential sites of care. That's how the state of California sort of operationalized this program. And I've also had the opportunity of participating in a number of other grant-funded contingency management programs operating here locally. So it's been a really exciting thing to see what is the recommended standard, which is contingency management is the recommended component alongside every other care modality for stimulant use disorder. And then to actually operationalize that for community members here in LA has been really rewarding.
Wow. So I love the way you pointed out there that it's not an either or. In actual fact, they complement each other and can make things even better for society and obviously the people affected. Brian, you're not just a theorist, you're involved in the real world. So what makes CM or contingency management successful in that real world setting?
So contingency management has to be accessible. And that's actually been one of the big criticisms is, Brian, you say that contingency management's the treatment of choice alongside everything else, but where can I get it? At least here in California, we now have an answer. If you're enrolled in Medi-Cal, you can get it, and there's a whole list of places where you can get it. I have a very practical answer. That is not true in every state in the United States. So one thing is you have to find a way to pay for it, and there are now waivers in a number of states across the United States that use public funding to pay for this. In other settings, usually grant funding or the VA, they have their own funding sources to cover contingency management. The second thing is it has to be operated with fidelity. One of the things that I learned relatively early on is if you are working as somebody's counselor or, I'm a psychiatrist, right? So if you're working as somebody's practitioner, generally you're rooting for them, right? You want people to do well. And somebody comes in and says, hey, I really tried to abstain from meth this week and I only used once. And they P positive for methamphetamine. Well, if they're in a contingency management program that is based on urine verified abstinence, it's really important that you withhold the incentive related to that toxicology finding. But you might be torn as a practitioner. So one of the other principles is if you're going to use the immediate reward mechanism, which is like the fidelity model, this is how contingency management works. It's oftentimes helpful if it's administered by somebody who doesn't actually have another relationship other than being the contingency management coordinator for that treatment. Doesn't mean that they can't do counseling for other folks, but it is helpful to kind of separate out the roles so that it doesn't actually corrupt the integrity of contingency management. It's really effective, but you have to operationalize it with fidelity.
Wow. Yeah. Yeah. You touched on two great areas there, Brian. Number one is availability. And my understanding of the state of California program, the incentive rewards program, there's now over 120 facilities across the state. And, that's above and beyond anything else in the entire nation. Your second comment about fidelity, yeah, I love that as well. Implementation and fidelity considerations. What are the components behind achieving that fidelity? Is it workflows, staffing, training, um, you know, policy, software? What is it that that adheres to that? As you said, making sure that they're adhering to that fidelity.
I guess I'd start by saying yes. Yes, it requires staffing. Yes, it requires workflows. Yes, it requires training. And just a quick word about software. What software brings is a way to make it as easy as possible, right? It diminishes the number of kind of thinking steps that an individual does where there's always the potential for somebody to, not follow an algorithm exactly the right way. So as much as automated, where you put in a urine result and then you are provided, okay, this is then what you should do next, right? In accordance with the protocol so that somebody doesn't have to then consult a chart, think about it, because there's always errors that can happen whenever something isn't automated. You have to make sure the software works, right? That it's programmed appropriately. And so there's fidelity testing of the software, but software really then helps make things easy so that when you do the training, you're training people around these are interactions with the client or how to actually operationalize the program with fidelity, but you're not stuck, reviewing things again and again. Like that, anything you can automate, that's one of the things that software can really do for a contingency management program. And then one of the things the state of California did is had a whole fidelity curriculum and then fidelity testing, right? And that delayed things. In other words, you couldn't just, as a site, raise your hand and start doing contingency management tomorrow. You had to go through the recommended curriculum, including the hours of training, and then the fidelity testing, and then the monitoring to make sure that you stuck with the fidelity that you learned. And that delayed the start of the program, but one of the things that we've seen in the state of California program is its success. 93% of the participants says this was a helpful program for me in order to support my recovery from stimulant use. I mean, that's a really remarkable outcome. You wouldn't have gotten that if, for lack of a better phrase, it was a sloppy program. And it wasn't, so you had to make sure that you deployed the staffing was there, that there was adequate training, that there was adequate monitoring, the software was optimally developed to reduce the number of, error points, and you made things as easy as possible. And I think that's how you generate results.
Yeah, that upfront planning and that quality produced, as you said, phenomenal results. And you just gave a statistic there of 93% of the beneficiaries or patients saying that this is helping me change my life, which is that's something we're all very, very proud of, obviously. Brian, you mentioned earlier, a little bit on funding. Could you just expand on that? Because as people are thinking about contingency management and we're going through changes, the world will always go through changes on funding. But what are some of the things that you're seeing out there where people are funding their contingency management programs?
Well, probably the most sustainable source of funding would be the federal Medicaid program. And we're not the only state with a waiver now that includes contingency management. So, fortunately, I actually think that there are roadmaps. One of the things that I think makes contingency management compelling, regardless of political philosophy, is it's cost effective, right? It does not cost that much to do contingency management, and reducing methamphetamine use and supporting, because that's the stimulant that's dominant in my geography, really then reduces the public health burden related to stimulant use and the healthcare costs that come with that. So it actually, there's a real sort of fiscal responsible angle for getting these waivers approved, kind of regardless of what administration happens to be in power at the time that those waivers go through. So it's a really actually exciting opportunity, I think, to be building contingency management into the federal waivers that make Medicaid possible. I think there are other types of contingency management programs that aren't as specific to stimulants, right? So there's housing retention contingency management programs, treatment adherence contingency management programs, and there isn't like a broad funding source. So oftentimes you're looking at grant funding and different jurisdictions, whether it's opiate settlement funding, or if you have another taxpayer source of funding, or if you have any state organized response funding, there are different funding streams that people have been able to tap into. And SAMHSA actually was very helpful at providing guidance on contingency management that made contingency management more flexibly funded and delivered. when it was operationalized with contingency. So those are all different funding sources that as somebody kind of involved with state policy that I would be looking towards for operationalizing a contingency management program.
Oh, well, thank you very much. We're certainly seeing, that one of the funding sources that you just mentioned was the OSF, the opioid settlement funding.
Yeah,
And, I think in the initial tranche of that, people were doing some, relatively straightforward actions like, bus signs and awareness and all of that. But what we're now seeing in kind of in year 2 and 3 is people are going, wait a minute here, let's shift gears and what's more evidence based and how can we actually move these funds into the best return on investment. And that's what you were kind of talking about earlier is, hey, regardless of anybody's thoughts on all of this, it's actually not only saving lives, but it's a really good ROI for society too.
that's right.
So, yeah, thank you for that. Brian, what are misconceptions, if any, that are still out there about contingency management? I mean, it's been studied and proven for 30 plus years, but for some reason we still bump into these what I call misconceptions. What are your experiences there?
The word contingency management is not an intuitive word, right? You sort of have to understand what contingency management is in order to understand what those words mean. Once you do, I think it's fine, but I just don't think it's a well understood concept. Um, in the state of California, the term recovery incentives program emerged as a term because that was a little clearer. You were incentivized for being in recovery. But then it can create the misconception, well, you're just giving people like gift cards and for what exactly? There's this idea that there's not actually a clinical thought behind this. You're just sort of like giving out incentives without a framework for it. And actually, contingency management is explicitly tied to a therapeutic framework, right? So, a few things in order to make sure that somebody's eligible for contingency management. There's a diagnostic requirement, right? So somebody's had a diagnosis made of a moderate to severe stimulant use disorder, and then they've gone to a location that is specifically trained to deliver that. So this isn't the state of California giving out incentives without a thought, right? There is a process to determine who is enrollable and who isn't enrollable, and a set of verifications and checks to make sure that the people getting this are the people that really need it. I also think that there's a misconception of contingency management is it's a great idea, but it's impossible, right? You know what I mean? It can't be done. And actually, that's not true at all. It can absolutely be done. And actually, it is an effort, but it's not an insurmountable effort, right? It's not an impossible effort. And I think one of the things that I've been really heartened by is, I hear from other jurisdictions, I can point them to the concept papers. I can point them to the protocols. I can point them to the stuff that's been developed. So people really don't have to start from scratch in terms of their program development. Then there's, I'll call it the more general stigma, right? Around like substance use treatment. Is treatment really effective? That's a myth that's really easy to dispel because contingency management is so effective and it's so much more effective than not doing contingency management that's why ASAM and the American Academy of Addictive Psychiatry in the clinical practice guideline recommended contingency management as the treatment of choice is just because its effect size is so strong.
You were talking there about a professional evaluation of who it should qualify for the treatment. That's the starter point. This is just not willy nilly here. This is very, very precise procedures. Number two, they're meeting people that are professionally trained. And then finally, there's that fidelity around the process. So there's no fraud, waste, abuse, or anything like that. And then that's what makes the whole thing work. And I think that really then addresses some of those misconceptions or false ideas that are out in the marketplace. When people are measuring outcomes, Brian, what are some of the things that you think that they should be focusing on in their reporting or ROI considerations for payers or policymakers? What figures do you hone in on or what results do you really like? Because you mentioned one thing earlier, which is the satisfaction from the patients or the beneficiaries, but I'm sure that there's others that kind of come to mind for you.
The most intuitive one is how long is people able to abstain from stimulants, right? Urine verified stimulant abstinence is actually an integral part of California's stimulant use disorder, contingency management program, and that's built into the model. In other words, some just by its very nature is going to capture data about toxicology verified abstinence. And another key measure is how long do people stay in treatment? The contingency management program is operationalized in California for there's two 12-week parts for a total of 24 weeks that's repeatable when medically necessary. But people can stay in treatment even longer, right? They don't necessarily stay in contingency management, but they can stay in treatment kind of as long as they need to. So you can look at how long do people continue to work a recovery program. But the most compelling figure for policymakers is going to be things like health service utilization. What do we know about the association between participation in contingency management and whether people get arrested or not, right? Or what we sometimes call recidivism, right? People sort of returning not just to expensive healthcare settings, but to carceral settings. So though and what we do see is a reduction in healthcare expenses, right? People are in treatment, but treatment is not nearly as expensive as an ER visit or a psychiatric mobile response team visit or needing to deploy like this is a small fraction of taking care of people impacted by stimulant intoxication and oftentimes the psychiatric and medical sequela of that. So we do know that there's a return on investment in the healthcare spend and certainly return on investment in the I'll just call it reduction of societal spend and burden, right, on the health and wellness of everybody in the community.
Brian, you're obviously based in Los Angeles. It's your home, and you know it better than anybody. But you've had a lot of exposure in other parts of the country, particularly with your role at ASAM. Could you just share with us if there are any differences in different regions that people should be aware of?
Sure. Well, the Veterans Administration, which is a national program, has been sort of offering a contingency management program actually for a while. And while it certainly includes people with stimulant use disorder, there's other contingencies that you can have, right? So, as an example, Hawaii has an approved contingency management program that includes stimulant use disorder, but also opioid use disorder. So, looking at and there's contingencies that you can build both around urine verified opioid abstinence as well as adherence that is possible. And so I've seen grant funded programs in different jurisdictions that include both stimulant and opioid use disorder. And if you look at like overdoses as just an example in the United States, it's driven by fentanyl, which is an opioid, and stimulants, whether we're talking about methamphetamine or cocaine. Those are the big drivers of the most recent overdose crisis. So it makes a lot of sense to use contingency management focused on the big drivers that are driving the overdose crisis. There are contingency management programs approved in the Medicaid programs in Washington and Montana. I think Rhode Island is pending approval, Michigan's pending approval, New Mexico is, I think, about to launch. And I think one of the health plans in Delaware is also approved. So we are seeing a growth across the country of Medicaid funded contingency management programs. But I could point to a number of grant funded contingency management programs, again, using a whole variety of whether it's philanthropic grant funding, opioid settlement funding in a whole number of jurisdictions across the country. And yes, it includes stimulants, but it's not restricted to that. You could look at other substance categories and other behaviors to make on which the incentive is contingent.
On that note, Brian, where do you think contingency management is headed to the future?
I'm really interested in contingency management being accessible beyond the specialty SUD system. So just to talk this out for a moment. In the state of California, we have a drug Medicaid program. It's called DMC. And our drug Medicaid program is focused on people who are enrolled in substance use treatment. It makes a lot of sense to put contingency management there. That is what that system is designed to do. But specialty SUD systems only reach between 5 to 15% of people impacted by substance use. So anywhere between like 80 to 95% of people with substance use problems actually goes to specialty SUD treatment. So I would be really interested in seeing contingency management operationalized in primary care, in specialty mental health care, and in street medicine programs and outreach programs. And you could focus it on stimulant absence. You could focus it on participation in housing, other treatment activities. I mean, so I think of both a broadening of setting and deepening the number of different behaviors and conditions. I think contingency management is a really powerful tool. I'm glad we have it for stimulant use disorder, but I think it's a really powerful tool to use across a variety of conditions in a variety of settings.
I think this is my last question, Brian, and that is there a question that you were hoping I would ask you?
Yes, I'm going to make a statement and then I'll pose the question.
Fantastic.
So one of the things that's been really exciting about the contingency management program is it represents an investment in substance use systems. And that's one of the things that's sorely needed. Substance use systems are underinvested in. We don't necessarily see the same rates, despite federal parity rules, the same rates or investments. So, my question for you is, how should we invest in specialty substance use treatment in the United States?
Okay. So, how should we do that, Brian?
Yeah. So I think we need to be thoughtful and intentional around actually using value based incentives for systems, right? So, one of the things that contingency management has demonstrated for clinical outcomes is that when individuals have a reward or a prize when they show up twice a week, provide a urine that's negative for stimulants, that they will generally show up, provide a urine, and continue to participate. We can see that type of when people have a reason or an incentive to do things, they tend to do them. Principle of contingency management. What we haven't seen is a investment in a payer system for substance use system that actually puts additional resources to get wide adoption of the ASAM criteria or whatever the comprehensive psychosocial treatment is model is, where people can really build care around the person's ideas and values and intentions. So we sorely need investments, public investments, private investments in specialty SUD care. And it's not just investments in X or Y modality. It's really deepening the specialty SUD system to be more person-centered.
Wow. Yeah. Thank you very much. That is outstanding. I mean, just in those last two questions, Brian, you've really expanded out what the future might look like, and I do appreciate that to address, the vast majority of the potential needs that are in society today. Brian, I have thoroughly enjoyed this time with you. I always do when I'm talking with you, and I always learned a lot, and I think that all of our listeners will too. So thank you very much, Brian.
Thanks so much for having me.